Good evening, everybody, and welcome to this edition of the
Deputy Director of Research and Strategy and the Director of Women's Health Tech Initiatives at HitLab. At HitLab, we are building a Women's Health Tech Initiative, an effort that aims to provide resources and innovative solutions to issues of women's health. While women's health is currently a $1 billion industry, this market is projected to reach $56.8 billion by 2027. We're reaching out to health tech industry leaders to find ways to collaborate on and build the initiative through sponsorships and creative ways of diffusing information about the importance and potential of this field.
Hi, this is Abby Stern, Program Manager of the Women's Health Tech Initiative at HitLab. Part of our Women's Health Tech Initiative includes hosting our upcoming virtual Women's Health Tech Challenge on May 21st. We're calling on femtech innovators to apply for the challenge. If you're interested in attending, applying, or sponsoring, please contact us at womenshealth@hitlab.org or visit hitlab.org/WHT. We're so excited to partner up with impactful leaders like you.
Fantastic, and welcome everybody to the HitLab seminar series. Today we're going to be talking about digital health in the age of COVID and reshaping the future of healthcare. And this has been brought to us by Medacity, our phenomenal partners in patient connectivity. And we really are excited to have with us tonight just a phenomenal panel with extraordinary experience in digital health, and all in really touching the different aspects of COVID and all of the work that they've done in digital health now affecting a lot of the COVID response. First of all, from the University of Maryland, Baltimore County, we have with us, again, I think one of the leaders in digital health and research, Dr. Wendy Camilo Castillo. And again, I'll let each of the panelists give more detail on their own backgrounds. But again, Wendy is an assistant professor in the Department of Pharmaceutical Health Services Research in the School of Pharmacy at the University of Maryland, Baltimore County. Coming in live from San Francisco, from the University of California, San Francisco, and the Innovation Center out there known as the Health Hub, is Mark Goldstein. And again, Mark is someone with an extraordinary background in digital health, not only as someone who's leading the charge of digital health from academia, but someone who has a lifetime of experience in venture capital and is currently serving as a managing partner for the Advisors Fund. And then also we have with us someone who's, again, more local, Dr. Matteo Margololi, and he comes from not only the NYU Grossman School of Medicine, but also is affiliated with Columbia University and is teaching there as well at Teachers College. So again, welcome to our distinguished panelists, and thank you for joining us on this Thursday evening in the midst of this COVID crisis and this outbreak affecting not just the coasts anymore, but now the heartland of America. And what we all have come to understand is that this is going to be something that is going to transform digital for the long term. This is going to transform healthcare for a long time. So the past was only 6 months ago, maybe 3 months ago, when healthcare had its more traditional forays and its more traditional systems. And the present now is one of the is easily, it's not even debatable, the most rapid transition of our healthcare system in its history, with systems moving to digital at epic rates, not by course of choice, but by course of need. And what we're seeing is an extraordinary transformation, something that we hadn't seen anything like until really the movement of physicians' practices and hospitals to the EHR from 2010 to 2015, where we saw the adoption of electronic health records move from one side of the downside of 50% to any physician practice, to literally the endpoint of nearly everyone now using electronic health records by the end of 2015. So with that introduction, let us meet the panel. Let's start with Dr. Malgorli. Please, sir, if you could introduce yourself to the audience.
Yes, hi, a pleasure to meet you. And funny to see the photo speaking how much time has changed. I had hair back then when the world was normal. Now we have to rely on these resources we are available. I'm very excited to come here and be able to speak about digital health with you. In my case, I'm actually in a dual position, and I'm a clinical psychologist working there, and we also do research in the context of trying to apply psychotherapy and behavioral health intervention into digital health. And the bridging between those two comes through the use of computational tools, particularly machine learning tools. Hopefully we'll have a chance to get a little more technical about that later. And as you said, also I'm local. I come from Columbia University in terms of my education, and I also teach there, as mentioned before. And I was wondering if we want to start maybe discussing about the recent situation, especially coming from New York. You know, the COVID-19 pandemic for us has been extremely challenging. I would say, in particular for healthcare workers. You know, I would say that in a context like this one that we are having now, reaching out for mental health support, whether psychotherapy or other intervention, I would say is more important now than ever. And I would say importantly to not only to all the audience who are listening to us, this is not just something that should be done for first responders. I think it's normal for everybody involved right now to feel stress, fear, and anxiety under their circumstances. You know, whether we have a loved one who may at risk, or even like people who are relatively healthy but could be suffering from social isolation, financial concern, and so forth. I would say now, no more than ever in this time of crisis, there's need of these behavioral health interventions. However, as I mentioned before, we are now in a time where the normal circumstances in which behavioral health intervention has started, you know, like these vis-a-vis interactions are not possible anymore. And this, I think, propels something that started a while ago, which is the application of telehealth solution, which became from some sort of, I would call it, if not a crutch, sometimes some sort of like alternative possibility to meeting into the primary vehicle for that, and an indispensable tool. Which, you know, is interesting in a time of crisis like this, we can bring an innovation. And I would say, you know, if I can do like a 1-minute commercial, I would say NYU has done a really terrific job in this. They made available a lot of resources, not only to the staff in general, but also to moving all our patient work directly to telehealth now, and to the first responders involved now, which also includes residents and fellows at their first serious experience. They made available a lot of support groups, self-help apps application to assist them in a time of stress like this. So it's a very, very fruitful time to be able to be in a digital health field.
Absolutely agree. Thank you very much for the introduction. And now our next panelist, if you could please, Wendy, if you could do just a brief introduction of yourself for the audience.
Sure, Stan. And well, first of all, thank you so much for the opportunity to be here. I am assistant professor at the University of Maryland in Baltimore. I am a medical in the Department of Pharmaceutical Health Services Research, and I am a medical doctor by training and have a doctoral degree in epidemiology. My research mostly focuses on the evaluation of the effectiveness and safety of treatments, mostly in vulnerable populations. So some of the populations of interest have been pediatric populations and young adults, minorities, and pregnant women. And some of my most current work focuses on the use of digital health to improve our understanding of treatment, specifically among adolescents who have mood disorders and that are treated with psychotropics. Because even though there's evidence from clinical trials that shows that some of these treatments could be effective, in the day-to-day practice, it's very difficult for clinicians to determine, and for caregivers as well, to determine whether a given treatment is actually having the expected effect. So we are hoping that digital health can inform our understanding of the safety and effectiveness of treatment, and of course, provide more evidence for clinical decision making in mental health.
That's fantastic. Thank you, Wendy, very much for the introduction. And then Mark Goldstein coming to us from San Francisco, UCSF Health Hub. Mark, if you could give us a little bit of your background as well this evening.
Sure. Thanks, Stan. My background, well, I'm a native New Yorker, but I've been out here on the West Coast for about 30 years. I have two lives. One life is I'm a venture capitalist, and I spend most of my time actually investing in digital health related solutions. I've made about 35 or so digital health investments over the last decade. My other life is I run the innovation center at UCSF called UCSF Health Hub, and we're only a few years old. We're backed. We're a nonprofit, and we're actually backed by the venture capital community out here in Silicon Valley. And our role at Health Hub is to accelerate change in healthcare and to really match great innovators with the clinicians, doctors, and that they need, do great things similar to what HitLab does in New York. We see ourselves as the HitLab of San Francisco. How's that, Stan? There it is.
Yeah,
and
we love it.
So I've gotten to know HitLab, huge fan of HitLab. I've also recently made an investment in a company called NeuroFlow, which is a Philadelphia-based company doing mental health, basically helping mental health, and their whole business has been transformed as it relates to COVID. But I'm excited about this panel. It's been an insane last few weeks. I think me and my peers, we've never worked harder, but we're scared that the wave of New York is going to hit us here in San Francisco, and it hasn't quite happened yet.
Yeah, let's hope it doesn't as well, Mark. And again, thank you for joining us. Look, I think to lead things off, Matteo, I'd like to talk a little bit about some of what's going on right now in mental health. We obviously have seen a rapid transition across the board with what's happening in the virtualization of healthcare, remote patient monitoring, telemedicine. Certainly, that's been a massive shift. When you look at some of what's happening to our society, you see a lot of anxiety. You see a lot of folks, almost PTSD-like symptoms. Certainly, the frontline health workers will have enormous behavioral and sorts of issues that they're facing. And then we have folks at home who've been sheltering in place for a month or more now. So from your standpoint, when you look at some of the remote mental health treatments, some of the digital health tools and mental health, what are you seeing as some of the most efficacious tools that are out there for behavioral health treatment remotely?
This is a great question. Like in a time like this, as you were mentioning, it's absolutely not only a frequent possibility to have some sort of stress, fearing this, having panic, having social isolation, and also what you call like potentially stress reactions to the event. So this leaves us a very broad spectrum of the possibilities in which people need help with. And thankfully, digital health, I think, has a spectrum of possibilities that are open. I would say the first and crucial thing we can think of is that the normal interaction we'll have with a mental health worker, could be a psychotherapist, could be a psychiatrist, psychologist, and so forth. It is possible to this day through the use of telehealth applications, meaning that especially there's a series of paradigms in terms of video conferencing possibilities that allow for what we'll call like synchronous therapy, meaning having some time with either like a therapist, again, or a licensed mental worker, and to have a session as it was normally done if you would come to my office in Manhattan. And actually, interesting enough, this is something that at first really surprised me, but when we work in this field, we clearly can understand and have a grasp why this kind of video conferencing is as effective as psychotherapy in person. And there's studies about this that go through, I would say, almost 15 years to discover this is not something new. What is interesting now is that finally we are at a point in which people, even that will skeptics of this kind of technology, have no other options but do this. And they find themselves in a situation where this kind of interaction, like the one we're having now, is the only way, even maybe to talk with their own therapist or even meet new therapists. So we say this is something that actually is being rolled out by most of the mental health institutions and hospitals. But beyond that, then is the question: if I'm starting now, if I'm in a position where I don't have this connection and I'm not sure whether I will go to a hospital, what is that left for me? Well, other than this enrolling that we have also in various hospitals where you can start even from scratch therapeutic relationship this way, there's also some private options. And there's a few leaders in this field. Talkspace is one of them, but also BetterHealth and are the two main brands when it comes to possibility of having remote therapy coming from privately, and they offer a range of solutions that is a little more broad than just online conferences. Perhaps we can talk more of that later. Beyond this, more again, close to in-person modalities, there's a lot of applications, and perhaps some of the other panelists can mention them, but some of them come to mind. There's a lot of like self-help, self-coaching modalities, for example. One come to mind that being recently worked with also in the concept of NYU is a way forward that allows like these health self modules that we know are as effective as having cognitive behavioral treatment in person through the use also of a coach that helps you. And beyond that, I think there's a plethora of applications that offer mindfulness therapy intervention, like Calm is one of them, Headspace is another one, and so forth. So it really depends on the kind of symptoms that people are presenting right now and all the things they believe they need help with. It goes from the fact of even being able to talk with someone, or for those who have more specific need, there's apps tailored to them.
That's perfect. And I know, a lot of the work that you're doing is also is supplemented and really impact as well with the work that Wendy's doing. And Wendy, a lot of the work that you've done over the last 10 years has been focused on women and youth and minorities. A lot of those populations we're seeing now, and some of the early results of what's going on with COVID, they're being affected by this much more significantly than other populations, and which is probably no surprise to you. You're probably someone who could have predicted this a long time ago. So given the some of the social determinants of health that you've seen impact in these populations over the last 10 years, and given what's happening with COVID, what are some of the behavioral health issues that you see popping up in those populations?
So definitely one of the challenges is actually being able to reach out to these populations at this point. So some of the reports that we have them from community organizations, which have like a stronger footing in the communities, because then it becomes an issue of trust. What we're seeing is that there's sort of like two levels of patients that are currently reaching out for services. So those of which who are comfortable with technology, but also who have trust in the system, that the system in some way is not going to put them in harm's way, being, for example, that their information is not going to be disclosed, or that their whereabouts are not going to be disclosed. We have a second group of patients or members of the community who feel that the risk of connecting with the system is much higher than the benefit that they could potentially be getting. And therefore, their main sort of source of support then becomes all these grassroots community organizations, their own patient groups, potentially their family members. And the challenge, as Mateo was mentioning before, is that then what you have as therapeutic option is all these self-help that therapies that can come in the way of digital apps, or that can come in the way of social support. I think one of the biggest questions that we're asking at this point is whether that's enough to be able to support all these patients that potentially are not wanting to access care through the use of technology, and whether we can in some ways build trust with them so that we can create or develop secure pathways through which they can receive the support that they need, not only to cope through like what we are calling the acute phase of COVID, but what will this mean moving forward when the acute phase is gone and the system has shifted into a full virtual or full telemedicine mode of delivering care. So at this point, I guess what we're seeing is the gap. Honestly, we still have a lot of questions. We are definitely in close contact with these community organizations, the community support groups. But we do see that moving forward is definitely an area that we will have to be more, intent about in terms of not missing huge gaps of the population in terms of coverage with healthcare.
Yeah, I think that's going to be something that we'll have to see play out as well as this unwinds over the summer and into the fall and next winter. We'll certainly see it. We have a number of colleagues in different neighborhoods around New York City, and Jamaica Queens Hospital has been one of the hardest hit. That neighborhood, that area of Queens has been just ravaged by this disease. Large families living in small apartments, homeless people living in shelters, where the spread has been just devastating. And they're going to have, and they already have, the same sorts of mental health and behavioral health and emotional responses that we're all having to this, and the need for the support, from what you're talking about in terms of being able to bring them applications or other types of digital interventions is going to be critical. Mark, from your standpoint in San Francisco, obviously there's, you have a number of phenomenally successful behavioral health, digital health applications, not just in San Francisco, but in the Bay Area. And you also have a number of homeless in the Bay Area and San Francisco especially. From your standpoint, what are some of the major lifestyle changes in general, but specifically since we're talking so much about behavioral, mental, emotional health here as well, do you see COVID changing and having an effect on in your area and nationally?
Well, let me take a step back, because this is so much broader than behavioral health. If you think of what's happened here with COVID, I mean, the genie is out of the bottle. Telehealth, and Stan, you mentioned it, healthcare as we know it is going through a period of change that we'll probably never see, clearly we'll never see in our lives. And what was the past is not coming back. And we all have to accept it's gone. Private practices will never operate the way they were operating before this COVID. That applies obviously for individual therapists. Telehealth is simply a better way, remote diagnostics are a better way for patients to work with their care teams. It's just not exclusively. Telehealth augments the process. It's not going to replace people. It's the same. This is what people were saying with when the AI tools came out with radiology, that, oh my God, radiologists are going to go away. We'll never need them anymore because AI is going to replace them. It did not happen, and it will not happen. AI is augmenting them. The same thing that's going on here with telehealth. So everyone has to stop being nostalgic about it. The genie's out of the bottle. We're in this new world. And this new world actually can be wonderful. And Stan, I was telling you this morning, I had an opportunity to be a part of a Shiva. And for those who don't know, a Shiva, it's it's a Jewish tradition when someone dies, everyone gets together and pays their respects. Well, this was a digital Shiva. And so everyone did it on Zoom, and a fantastic man passed away. But this digital Shiva got 800 people from around the country to basically be a part of his celebration of his life. And the average age was 75, and most of the people loved it. Most of the people said they're never going to go to a Shiva like they used to again. And it just was representative of, wow, it took COVID to basically change everything. And I think we all have lots of examples of this. Specific to behavioral health, obviously the homeless problem in San Francisco is huge. It's somewhat unique for a variety of reasons. We haven't seen what you've seen yet in New York yet here. We're all fearful. We now have no transit system for, for all practical purposes to get people around. And we're not as densely packed as they're in New York. So we're going to see some incredible implications. But really getting to your question, behavioral health is changing. All forms of healthcare are changing. And, we're living in this new world of remote diagnostics and virtual health. And it's important for all of us to embrace it.
Yeah, absolutely. And if you take a look at the slide for our attendees, and we begin to look at how 2 months ago this map was predominantly blank, almost no coloration whatsoever of the transmission and the spread of COVID-19. And now a mere 60 days later, we're looking at a stunning infection rate, we're looking at a stunning death rate. And like Mark was saying, the scary thing is that we know that it's out there, it's hitting the villages and the towns and the communities in middle America now. And we're waiting for surges to affect people in rural areas that maybe don't have hospitals or the kinds of facilities that are needed to combat this anywhere near where they live. And so this is, again, we'll go back to this rapid transformation, but this is an extraordinarily rapid transformation. And as the economist John Maynard Keynes had talked about, these animal spirits that humans have, this animal spirit of what once was a habit, and once was a formation of a pattern, of a protocol, of going to the physician, of sitting in a therapist's office, or of going to a shiva, like Mark was talking about. Those patterns, those animal spirits, once changed through a shock, like what we're seeing here. And this simply just 2 months right now. I don't know if you remember, but March 10 was kind of a typical day. March 11, all of a sudden, we saw the NBA season canceled, the MLB canceled, European flights canceled. And in a short period of time, we went from, somewhat of a fluid state of normal to New York City schools being shut down and a lot of other school systems shut down, literally 3 days. And so I think this rapid transformation, this rapid adaptation is something that everyone's really trying to get a hold of. And Matteo, in your practice, aside from telemedicine and video conferencing, what other interventions do you see yourself utilizing, and other behavioral professionals, behavioral health and mental health professionals, psychologists, psychiatrists utilizing in their work as a means for adapting their practices for this new healthcare order, if you will?
Yeah, no, thank you, Stan. I think this is a really interesting question. As Mark said, we really open the bottle now, and there's a plethora of opportunities for other modalities of treatment to manifest now. Not only because of need, because now we're in a situation where, as you mentioned, most people can be experiencing some sort of stress and may be looking for some coping, but also because of the possibilities to try to make help available. And I'm going to give you a very clear example. We have physicians in the ICU and DR who are working nightmare schedules, and sometimes they are faced to make decisions in terms that would be very tough for anyone to make. And this, I think, is something extended to the entire New York system or hospital system, when you have to make choices in terms of get like critical care between two patients that under normal circumstances both will get it. And I think this can be a form of stress, and without very little time to use one of these online synchronous video conferencing methods. So what is left? Then it comes the possibility to use asynchronous methods. And by asynchronous methods, we mean any form of communication or interaction with a therapist or a mental health professional that happens indirectly. A very clear example of this, for example, will be messaging. And I think by one of the changes we've seen in this new situation where we're facing now, a lot of us are starting interacting with our family, friends, and maybe we haven't heard from a while, saying, "Hey, is everything okay? What's going on with you?" And a lot of the interaction happened also via messaging communication. So there's some entities also as we're saying, in the private sector, who are trying to use this asynchronous therapy. And as you mentioned, also Talkspace is a very big one in the field, also Better Health, with the idea of trying to use messaging interaction as a way to deliver therapeutic treatment, but also for people to share their thoughts, not just with not just with somebody there to listen like it will be in a crisis hotline, but with professional counsel and in a way that can be helpful. Beyond that, there's a lot of self-guided possibilities that go through courses, online seminars, the same way that a lot of us now are trying to catch up with all of this open universities offering in terms of other courses, programming, and so forth. The same can be done with mental health. There's a lot of very incredibly good psychotherapists or, again, like mental health professionals that offer courses in terms of how to treat with depression, sleep hygiene, with the obsession we may be having right now. Those are very interesting things. I would say beyond that, and that's why I was saying this is kind of like something we have to balance, beyond that we have also an infinite range of possibilities. Because now that everybody is open to this possibility of technology, we have phones, which, as we know, Tom Insel, which was the former leader of the NIMH, the National Institute of Mental Health, really believes in the fact that we can have even digital biomarkers out of use of the phone. So this is the possibility. Can we infer in people's mental health based on the use they're doing of their digital technologies? Can we extract more information that will normally be available as a way to intervene when possible? So in other words, we have these two possibilities for people to reach to their counselor or therapist in any moment they want to through this technology, but also for the therapist to intervene and perhaps also to target people based on when these technologies will inform them that maybe this person will be in need of help. Maybe they're having a stress moment. So that leaves a lot of possibilities, with the risk at the other side of the gene of the bottle that these are all medical interventions, right? So we need to do some research and some work to ensure they do what they're sponsored to do.
That's precisely right. And that's going to be a challenge, right? Within that, this kind of current environment isn't something that's going to go away soon, but we know it's going to go away at some point. And so how can organizations set themselves up to transform today so that they'll be in a better position tomorrow for 2021 and afterwards? And that's a challenge in and of itself. And Wendy, going back to you for a minute, in going from really Matteo's viewpoint and perspective on this specific patient, from your point, more of and your viewpoint and vantage point of more population-based interventions, what do you see happening relative to more programmatic interventions for behavioral health within, again, these populations that you study so closely around, again, women, youth, and minorities, and what kind of interventions and what kind of programmatic changes do you anticipate seeing to be able to reach those populations on a behavioral and mental health side?
So I think that the biggest opportunity is actually for health systems to now test the potential for these technologies to actually improve quality of care and improve access to care. So far, very few health systems, I guess with difference to, or with exception with telemedicine, because telehealth has, I think, slowly been permeating health systems, also because payers are more willing, to cover for these types of visits. And now under COVID, they have almost been forced to cover for telehealth visits. But what I do envision is that now we're going to be moving in health systems a little bit beyond telemedicine, beyond e-health, into potentially the use of m-health. And as we know in the market, there's tens of thousands of apps in particular that are related to mental health, but we have very limited evidence of their effectiveness. So what I do see happening at the population level is that as people start using more of these apps in ways of either self-guided treatment or because they're directed by their providers to use these apps, we're going to have the ability to test whether these therapies actually work and whether they work in conjunction with the more standard treatments such as cognitive behavioral therapy or psychotherapeutics. So what I do see moving forward is that we're potentially going to see more evaluation around how these, for example, I see them as packages of treatment, right? Where you have kind of like the standard of care that is delivered through telemedicine alongside with the mobile health component. And how do we assess them in the long term and in the short term in terms of how they're impacting outcomes on populations? So, for example, one way in which we are thinking that this could work is in relation to the app that we're currently developing, because as of now, clinicians in some way were hesitant to think about the use of the app as a way to monitor treatment in youth who are initiating antidepressants. But in the current environment, what the conversations that we're having is that this is very likely going to be something that they're going to be using, because it's going to be a better way to actually monitor patients, especially if they can't see them in the clinical visits. So what I do see happening as well is that clinical providers and health systems are just going to be a little bit more receptive to testing and trying out these technologies, and which in the end will generate evidence that will allow us to understand how to better use them, which technologies are more effective to which populations, because not all patients may be amenable to all of these interventions. But all of these questions, I think, is the future of what we're going to be answering in the years after COVID.
Yeah, and those are going to be some tough questions to answer without a doubt, and it'll be tough as we move forward to figure out which are the best technologies to respond to this and which are the most responsive to the patient's needs and the community needs. Just as a reminder to our audience, please do instant message me any questions that you have. We have plenty of time to take questions, and would love to have some of you engage in the conversation. And Mark, talking about some of those challenges that we're facing, some of the questions that we have to answer in the future, again, you're coming from the standpoint of someone who's playing a role not only in the academic side with UCSF, but also on the venture side, as someone who's been doing venture for a long time and looking at trends. You're always looking at trends, and you're trying to understand, where is the puck going to be next? You don't want to know where it is now. You're trying to understand where it's going so you can be there when it lands and get the best shot on goal. Tell us a little bit about not just the specific trends around behavioral health and mental health, but also the more general trends that are going to transform patient care. Now, where are we going to be in a year or two with the post-COVID healthcare system?
That's a layup. I love it. Thank you, Stan. So, look, I'm going to echo. First of all, I'm going to echo a lot of what Wendy just said. Took on this opportunity with UCSF because, look, even though my career has been in digital, lately digital health, it used to be in e-commerce, I was in fintech, and we've seen digital transform everything. In healthcare, it's all going to be about augmentation. It is not. Doctors and nurses simply cannot go and will not go away. So digital is simply going to be complementing and augmenting the old way that things worked. And it's going to make things, in my opinion, a lot better. So when I look at making investments as a venture capitalist, when I look at things from my UCSF lens, UCSF has plans to completely rebuild their main campus. They're going to be spending another $5 billion on physical brick and mortar to build another campus because we know it's necessary. So it's not like this brick and mortar isn't going away. However, this new campus, and if you've been down to their new Mission Bay campus, it's built with digital first, digital in mind, just similar to what, pretty amazed what's going on at Penn, how they're building the new center at Hub. It's the same thing. So with digital in mind, so what does this mean? It basically means it's like, I cited this company NeuroFlow. And NeuroFlow has done a great job, and they sell this system, and it's like Calm, it's like Headspace, but it's built around therapists. And their primary client is actually the VA. And the VA lately has gotten an dramatically increased workload, as you can imagine, because of the stress and everything that's going on. If they didn't have NeuroFlow allows them to better manage the workload, in part with, now they can move more people to telehealth. They can watch as people not only check in with the system, do exercises at the home, they can monitor them, they can do third-party device integration. So people can behave at home as they would within their office. And so this is extending their office. And so from a VA perspective, they don't want to build more VA hospitals. They want to basically use them a lot more efficiently. And I think that's what Wendy was sort of inferring. So I believe the future and the biggest trend that I see is around augmentation, and is around basically recognizing that doctors and nurses aren't going to go away. What digital health can do, it can be predictive, It can help us manage pre-procedure. It can basically watch what happens post-procedure, and net is the patient is going to be get significantly better care.
That's brilliant. And so, I think with that, we have just an enormous amount of responsibility as digital health leaders to take action and to be a part of how to put together the next generation of digital health tools. And Matteo, one of the things that you have a particular interest in is artificial intelligence, machine learning. Talk a little bit about what you've seen in that area and how that might be applicable to what we're going to face, since a lot of machine learning is built upon large, consistently clean databases and data to build algorithms and to build patterns. How do we do that within COVID, and what are some of the applications for patient care going forward?
Yeah, I will say the question for COVID is probably more limited in the response is the fact that, as we know, a lot of people are expressing their stress or their distress through a lot of digital media, because that's the only way right now where they can communicate. So that may inform us of people who will be more at risk. What I would be interested in, which I think is also the interest of other panelists here, is what will happen when the crisis will end? How can this inform our practice? And I think the machine learning in this sense can offer us a new way to really improve the approach to mental health care in general. And the reason why this is possible in conjunction with digital health is because digital health has this great advantage. Meaning if I'm talking with a patient on through an app or through a digital device, this flattens the entire surface of the interaction between me and the patient, meaning that all the data is recorded and all the data becomes available for further kind of analysis. And as we know, psychotherapy or also psychiatric approaches have a lot of questions in terms of what works for whom. We're not at a point yet in our science where we know what is it be effective for one person priori, and this is something really important. And the position that machine learning approaches can do is twofold. On one side, I think we will be able to a point to analyze patients better, in a point of possibly even getting some sort of digital phenotypes that can inform us of how patients actually respond to treatment, the way they interact with the other, with the therapists and so forth, that potentially can inform of what will be the best treatment based on their own profile. And this is definitely one part. Another component, I think, has to do more with the therapies per se, which, as pointed out, this is not a technology that is supposed to replace humans. I would say even in the context where we will create the perfect therapeutic Freud, if we gave a patient an option, would you choose a human being or a computer? I'm not sure everybody will choose the human, true, but probably the majority would. So in the context, I think we need to conceive the fact that these tools can help and make better clinicians and better therapists. I would say the same way that now, if I'm doing some sort of office job, I'm supposed to know the Windows package, Word, Excel, know how to navigate through my email. I think at a certain point we'll find in the same position where these digital tools can help us and inform any kind of therapy practice. In terms of more specific ways, I think a lot of the work will probably come from advancements in natural language processing, especially in the context where we'll be in a position where we can quantify patient and therapist interaction better. We will find a way probably to get more specifically what are the teams talk, how patients react to certain specific interventions, what, for example, in the context of trauma therapy, what is traumatic memory, and if I do a certain intervention of exposure, will this be effective or not, which is something to think about in the age of post-COVID, with the hope that as we were, I think that many of us have hoped for, that this bridging toward more and more telehealth application will be maintained, because then again we'll have a lot of information where we can base this more empirical approach. This is my hope, that a lot of things that now we are kind of stumbling in the dark, we try to be scientific but we cannot quantify our interaction, through telehealth we'll be able to do, and do so we will be able to do pattern making with machine learning, hopefully to increase not only the identification of what our problems is, but hopefully what works for whom, which I think is that question that all of us have at heart.
Absolutely. And I think that's one of the bigger questions that we're going to see come to fruition over the next few years. And we've got a couple of questions from the audience now, panelists, around adoption. And we know that digital health on the patient level has not been widely adopted when it comes to many, many things. We know that, for instance, with some of the digital health tools like AliveCore and CardioNet and OneDrop, maybe ResMed, there have been maybe a handful of digital health successes with patients over the last few years. Livongo certainly has seen a lot of success with the employer model, but now we're looking at a different call to action. Now we're looking at a time where people are very eager to enter their data. They're very eager to find out what's going on with their bodies, whether it's temperature or whether it's heart rate. Things like this have never been more urgent for patients, for people, not just in the United States or the top billion, but in all 7 billion people on the planet right now. So with that call to adoption, again, unprecedented in not just digital health history, the short history of the .com era, the mobile era, now the digital health era, but even before that with biomedical informatics and bioinformatics, we're seeing this new call to action that we've just never seen before. And so the question is, and Wendy, I'll ask you to answer this first. What do we do to instill and to harness this energy, this incredible energy right now in the healthcare ecosystem around patients craving more data about what's going on with their body? Are they symptomatic? Are they asymptomatic and contagious? That sort of thing. And as we've seen, some of the early data we're seeing now is that it is critical to, if someone is infected and are not doing well, it's critical to get proper treatment immediately within first 48, 72 hours. Waiting beyond that is a lot like what we saw with H1N1, where if Tamiflu wasn't administered immediately, it was too late. It was going to be, at that point, something that was beyond past of treatment. So, Wendy, from what you're seeing with the populations that you study, with the work that you do on the digital health side and behavioral health, what kind of tools, what kind of techniques, technologies can we use to accelerate the adoption of digital within women, youth, and more minority populations?
Mm-hmm. Well, I think, Sam, the first thing to understand is that populations are quite diverse. And typically, when these technologies are launched, those who are better connected or better acquainted with technology are those that are more likely to use it. So those are like what has been defined as the early adopters. But what we need to understand, especially after COVID, is that we will probably have to think about what digital literacy means and what technology readiness means in the populations that in whom we want to deliver care that is now digital in nature. If you do a quick Google search, you will find that the term digital literacy is relatively new in comparison to health literacy. Because digital literacy encompasses a combination of not only understanding, some basic notions around your health and how you conceive health and illness, but also how do you use technology around that, right? And so to answer your questions, I think, one sees value in the use of technology if you see an immediate benefit. And of course, at this time when there's so much uncertainty, when you don't know if you're having allergies or COVID, people are very eager to have tools that they can use at hand to sort of have that sense of security back. As we move away from the acute phase and as we sort of start thinking or start realizing what transitioning into this long-term phase after COVID really means and the potential impacts on the health system, I think what we need to consider is what is the readiness of the communities to actually be able to adopt the wide range of technologies that are available. And I'll give you an example. So just last week, I was having a conversation with a faculty member from the Department of Psychiatry. And she was mentioning, in particular, she follows a cohort of patients with schizophrenia. And one of the challenges that they've been finding is that on their end, they were very quick to move into telehealth. And they sort of used a channel that they thought was very low tech to ensure that most of their patients would be able to connect. What they found was that, for example, for most of the patients, they had smartphones who were old technology and that couldn't support the platforms that they were using. So they couldn't use Zoom in an effective way, for instance. Or they didn't have access to internet. But because of COVID, some internet companies have now been providing high speed internet access to some communities, but that is likely to go away once we go past the acute phase of COVID. So I think, again, going back to your question, as we move forward and as we start realizing that this is the new way of delivering care, we need to account for the fact that the resources available at the community can vary quite a lot, and which means that we do have to be very careful about how we push forward these models of care, because we may go very high tech, or health systems may go very high tech when the community is not yet ready to adopt them. So I would say the first thing is you really need to understand what is the technology readiness of the community that you are working with.
No, that's fantastic. And Mark, would you like to jump on that too? Because I know you've done a lot of work around understanding the adoption of these sorts of technologies, and maybe you could talk a little bit about how do we layer in some of the financial incentives as someone who's invested in a lot of these companies. Some of the key questions that you always want to know are what are the financial models? What's the business model? How is this creating value to the system so much that someone's going to pay for it? Otherwise, it really doesn't make any money. It's not sustainable. So what do you see, Mark, as the accelerants of the adoption, aside from the short term, the next 6 to 12 months, getting through COVID, maybe a rebound or whatever? After that, what are the incentives that accelerate the adoption of digital post-COVID?
Well, you know, when you've seen a bunch of things, it all looks the same. And so timing and luck are a big factor here. And we've talked about, you know, early companies that got into, for example, into telehealth in the Gen 1 companies, and now we're in Generation 2 companies. Well, they got in and they had to fight an environment where there wasn't bandwidth, there wasn't education, there weren't smartphones, and honestly, there were older physicians and caregivers. All of that's changing. So with each year, especially in the physician caregiver community, you have younger and younger professionals taking on the roles of where you had, you know, traditional, you could argue, teachers. Same thing's happening in the educational world. So what's happening in healthcare, I had a company I tried called Blue Light. This is when I was in the e-commerce retail business, and I was trying to bring Kmart to the internet. And we launched a free ISP, and we had millions of people on our internet service provider. And we thought we were going to sell a lot of products from Kmart. Well, the truth is everyone had bad dial-up connections, and lo and behold, they didn't buy that many products. I also had a company that was sort of like an E-Trade before the internet. Great company, outcome was okay, no E-Trade. And why is that? Well, you know, times changed, and there basically was a critical mass of supportive technologies. I think this is what we're seeing here in digital health too, is we now have an environment, and it's accelerated by COVID, and the fact that, again, you're having service providers give that 3G capability at no cost. And you're teasing people and giving people the experience and showing what is possible. So these are the accelerants, you know, Stan, I think that you're talking about. We're all seeing them here in digital health. We saw them in the great Amazon days in e-commerce, as Amazon basically was able to take advantage. We saw them in the early days of fintech. We're now seeing this in health tech. So we're going to come back in 10 years. It's an unrecognizable landscape. And a lot of the companies that are purpose-built for today's technologies are going to be able to best take advantage of it.
No, that's fantastic, Mark. And I think, you know, really having that velocity of adoption is going to be critical here. So can we, will what we see happen over the next 6 to 12 months become permanently in place, like an E-Trade? Or will some of them wash out, like whatever the company is that you were interested in that didn't sustain?
Well, we all, us digital people, we all don't want our button to go away. And at some point, our companies get sold or they evolve and we become, somebody's something on somebody's website, and then we disappear. Is this going to go away? Is this transformation going? No way. That's where I started today, is like, we can't basically yearn for the past. Those one-on-one doctor visits, and the coddling that we got. At the same time, we also don't yearn for fax machines. So with fax machines, thankfully, going to disappear in the medical world, and honestly, a lot of these traditional doctor appointments disappear. We're going to move to this new world, and we're going to like it. I think it's going to be a lot better. It's going to give us a lot more freedom, a lot more time to do these sort of the things that we'd like to do, as opposed to getting on a bus and going to see a doctor.
Yeah, without a doubt. And I think that's one of the things that was written about in George Lundberg's book, Severed Trust. He published it in 2000. He's the former editor of the Journal of the American Medical Association. And, George talked about how managed care in the 1990s had significantly displaced patients' trust in their physicians because of all the decisions that they were now making that were financially motivated and had significant downstream consequences for outcomes. This era of COVID and digital disruption, will it enhance the physician's trust? Will it displace the physician's trust in that physician-patient relationship? How will this occur? That's not for this episode. This will be for the next episode of certainly the digital health seminar series and what we're doing here today. But I do want to thank you, Mark, and wish you, obviously, you and your family happy Passover, and everyone else happy Easter. I think the idea is that we're in an extraordinary time and doing extraordinary things. And again, the seminar tonight wouldn't have been possible without Medacity. Again, it's a leading cloud-based company. It's been around for several years now, been gaining a lot of momentum, a lot of diffusion, as we at the lab like to talk about, as it's able to connect patient populations, particularly with chronic and complex conditions. And so we want to thank Medacity, not only for their contributions to the healthcare system over the last few years, but particularly now with some of the platform pivots that they've made in bringing what they do into homes and to help organizations out during the COVID crisis that we're seeing today, particularly in the tri-state area. So thank you to Medacity, Tom and Terry specifically, Raj as well. And thank you to the wonderful panelists and the great audience for asking some very intriguing questions. We hope that you all stay safe and have a good holiday today and over the weekend. Thank you for joining us this evening. Good night.
Thanks.